The next speaker is Dr. Sunita. Okay, she will be speaking on a case of ocular hypertension provoked by water drinking during uroflowmetry.
Good evening, everyone. Myself, Dr. Sunita. I am presenting a case of ocular hypertension which is provoked by water drinking during a uroflowmetry. We report a case of open-angle pseudophakic patient who developed sudden onset painful diminution of vision in both eyes after drinking 3 liters of water within a short span of 1 hour. Consumption of water bolus has long been associated with rise in intraocular pressures in both open as well as closed-angle patients. It has been thought to supplant the 24-hour IOP monitoring as the rise in the IOP correlates well with the peak tidal variation in a given patient. A 54-year-old male patient presented to the eye emergency with complaints of pain, watering, sudden onset diminution of vision in both eyes. Patient was a known case of varicocele with mild hydronephrosis and had undergone a uroflowmetry prior to reporting with the above-mentioned complaints, for which he was asked to drink at least 2 to 3 liters of water. Patient had undergone right eye phacosurgery with PCIOL implantation 45 days ago, followed by left eye after 15 days in our hospital itself. Since the patient has been a postoperative case, hence patient was under regular follow-up and the IOP was recorded by NCT, was within the normal range in previous all visits. On ocular examination, the best corrected visual acuity in right eye was 1/60 and left eye was 2/60. Cornea was edematous with epithelial and stromal edema in both the eyes, with normal pupil with sluggishly reacting pupillary reflexes. Circumcorneal congestion was present in both the eyes, and both the eyes were pseudophakic with a deep anterior chamber. The intraocular pressure by NCT was recorded to be 55 in right eye and 52 mm of Hg in left eye. Rest of the adnexa and anterior segment was unremarkable in both the eyes. Patient was given an intravenous mannitol 20%, 150 ml stat bolus over 15 to 20 minutes. Half hour after giving the mannitol, the NCT was repeated and was found to be 34 mm Hg in right eye and 36 mm Hg in left eye. After the IOP reduced, the cornea cleared significantly. Patient had dramatically improved symptomatically with no pain and watering. Patient was sent home after prescribing tablet acetazolamide 250 mg TDS, eye drop timolol, brimonidine, dorzolamide in both the eyes. Patient was advised to follow up the next day in OPD. On subsequent visit, his IOP recorded by NCT was 23 mm Hg in right eye and 22 mm Hg in left eye with absolutely clear corneas. Patient was advised to stop all the medications and review after 1 week for further evaluation. The IOP recorded with Goldman applanation tonometry in next visit was 16 mm Hg in right eye and 14 in the left eye with no further complaints. Gonioscopy was done before dilating the patient for fundus examination, where all the angles were found to be open with no other abnormal findings. On dilated fundus examination with tropicamide plus phenylephrine, a normal fundus with 0.3 vertical CDR with healthy NRR rim was seen. His rule was followed with the normal AV ratio of 2:3. No wedge-shaped defects or splinter hemorrhages were seen around the disc. Foveal reflex was present in both the eyes. OCT RNFL showed normal thickness of retinal nerve fiber layers in all the quadrants, and all the medications were stopped and a review was scheduled after 3 months, and the patient was advised against drinking large bolus of fluids and to review immediately in case of any ocular discomfort, pain or heaviness. Water drinking test was first described as a provocation test for glaucoma in 1960s. However, it was associated with markedly unacceptable false positive and false negative results. In the 1980s, Amelie et al. Found a good correlation between the IOP and the water drinking test, that in the 24 IOP curve. Consequently, the concept about the water drinking test has changed and it is no longer used as a diagnostic test, but rather as a useful tool to assess the IOP peaks. Recently, this test was revived with a new purpose. It has been used as a surrogate marker for the outflow facility reserve and may be an indicator of the likelihood of progression of glaucoma. The mechanism of IOP elevation remains unclear, but there are some postulates such as limited outflow facility, increased episcleral venous pressure, increased IOP mediated by the autonomic nervous system, and the choroidal expansion. Eyes with lower outflow facility should experience higher IOP peaks after ingestion of water than eyes with normal outflow function, thus being a surrogate measure of the outflow system of the eye and its ability to respond to transient IOP elevations. According to the review published by Susanna et al. In 2017, an IOP peak in the water drinking test that exceeds 5 mm Hg is associated with 6 times increased risk of new onset of glaucoma. In addition, medically controlled glaucoma patients have a greater IOP increase with the water drinking test than patients who have undergone filtration surgery such as TRAB and deep sclerotomy. despite similar mean IOP at the baseline. This behavior is probably due to the fact that filtering procedures facilitate aqueous humor outflow more effectively than the medical therapy. To conclude, the role of water drinking provocative test as a diagnostic or as a prognostic test still remains debatable. However, those patients that may have to drink water bolus in a short span should be warned of the possible rise in IOP, especially wherein a patient might have to do it repeatedly. And a possible clearance from the ophthalmologist should be sought before putting patient through these tests, like as in uriflowmetry or USG scans in gynec patients or bladder cancer patients before radiation therapy. Most of these patients are elderly and have a higher chance of raised IOP. Post the test, so raise IOP post the test. So a before and after clearance from the ophthalmologist is warranted, at least for the first time the patient is put through such tests. Thank you.
I think it's an eye-opener case, because our urologist friends are getting this test done in virtually all patients of benign hyperplasia of prostate coming to them for problems.
Have you done all the investigation yourself?
Yes, sir.
And have you done it, or your originality is really it is because you have, I think you have taken the text from any part because it has mentioned in that.
Sir, I have given the references for the text that I have taken. For the discussion part only I have taken the
No,
references.
it's all right. One thing,
Yes, sir.
what should be the advice to the patient post-operative?
Post the test. So we keep the patient, we ask the patient if the patient feels, if he can come to the OPD and get his NCT checked, that is the best thing. If not, then he
How
should.
often?
Sorry?
How often?
How often is not necessary, but then
Yes,
if
it's
he's
necessary.
undergoing.
It's necessary.
It is necessary.
This is a provocative
patient
test
specifically,
that can
yeah.
induce glaucoma, it's all right. But with the aging process, the trabecular sclerosis will go on. Naturally, this is a test where this patient can develop your process to the glaucoma later on. Naturally, you have to keep him under follow-up lifelong.
He is under follow-up. He has been explained.
And
He
another
might
thing,
undergo the
this
same
test
again.
came, another thing you have to follow, every primary open glaucoma. Advise them please not to drink water so much
Yes.
amount regularly. Yes, you can take 250 ml or like that.
Thank you, ma'am.
Thank you, sir.
Okay, thank you, Dr.